But I think it's about realizing too. I think we need to realize that there is high value and low value care, even in a high value profession. So,
That's right.
as clinicians, if you're a DPT, if you're an OT, right, you have to realize that your skill set is being able to identify barriers to recovery and being able to create a plan of care that is viable and actionable. You're not the one who has to execute the plan of care, not the entire thing. That is why our profession has physical therapy assistants. That is why we can rely on trained coaches.
That's right.
It's already been done, right? And the coaches is a taboo term in physical therapy profession because they're non-licensed professionals. The truth of the matter is, if you have ever been in a physical therapy clinic, you know that there is at least a cohort of technicians that are running around and doing most of the exercise supervision, right? These are probably trained individuals that don't have a license that supervise your care because you have to juggle between 4 or 5 patients an hour in order to make this fee for service plan meet. So why don't we reorganize a little bit? And I know Drew spoke about this a little bit too, but there is a way of structured delivery of care using a team-based model inside an outpatient orthopedic setting where physical
Right.
therapist assesses, creates a plan of care. Physical therapy assistant is a skilled professional that can deliver that plan of care. And then technicians can be extenders for these redundant or non-skilled parts where you don't need a PTA to transition between different platforms where you need to do some neuromuscular reeducation. It can be a coach or a technician that oversees that redundant low value part. But we have to be the ones taking ownership of it instead of saying, no,
Hmm.
I went to school for 3 years. I need to be holding my patient's hand for 55 minutes every time because that we're creating our own ceiling. Then if you're going to be supervising your patients for 55 minutes at a time, your ceiling is like 8, 10 patients a day. And then what, right? Like, so at an average net revenue per visit for an outpatient setting, depending on the state, is like, let's just throw out a number, $110 a visit, right? Like, so $110 a visit will not pay the bills. Unit of production, your cost of unit production is about that. So that means that your salary, your overhead, your insurance, your EMR and tech stack, all of that combined costs about $100 a visit. So then how do you pay for your higher salary if you want to make twice as much as you do? You don't. You can't see 20 patients a day because then you're going to be working 20 hours a day. And then what? So you work smart, and you work smart. That means that you delegate responsibility. You are a physical therapist. Evaluate, create plan of care. Do intervene with patients, but not in a point where your time is being allocated to your service. Time is not equivalent to quality. Time is redundancy. Quality is knowledge. Quality is expertise. And we spoke about this before, where there's expert economy and there's skill economy. And we need to move
Hmm.
away from being skilled professionals. We have skills, but skills are part of the expertise. Expertise is knowing when these skills are necessary.
That's right.
And that's, yeah, so sorry. That's,
No, that's right.
Mhm.
I mean, the expertise is the higher bar. The skills are table stakes.